about half an hour behind, so I'll try to do it quickly, so to respect Dr. Liguri, he will not be upset with me.
No.
And this is a question that we sometimes are being faced in the daily clinic, that you have a patient with stage 4 disease comes to you with metastatic disease, now with a modern treatment, you get remission. What should you do about the primary site? Should you treat it or not treat it? Well, for those who are in a hurry, I can tell you that I don't have an answer. You need to use your common sense, so you may stay or leave as you wish. And then, according to American data, 6% of the patients diagnosed with breast cancer have stage 4 disease at presentation, but I don't think that America is a good example because I am not sure that they have screening everywhere. And I'm sure that the numbers in Israel are smaller because we have national screening, we're also a small country, and 20% of our patients with breast cancer, new patients, are with IVCIS. I mean, we are with the in situ disease, so for sure we have less numbers. However, historically, local treatment by surgery has been aimed solely at symptom palliation when you have a patient with coming to you with stage 4 disease. And there are some data that I'll show you that as if you treat the primary site, it's now becoming a hot matter. If you treat the primary site in the face of metastatic disease, you may improve the prognosis of patients. So let's look at that. Now we have evidence for the benefit of primary tumor excision in stage 4 cancer in renal cell for sure. There are at least 2 randomized studies showing that there was overall survival benefit when you remove the kidney despite the fact that there are metastatic disease. There's some works on stomach, colon, ovary, and melanoma, but this is less strong. So what are the treatment options in stage 4 breast cancer regarding the local site? You can do surgical excision, you can do exclusive radiotherapy, or can you do surgery plus radiation to control the primary site? And it's an area of debate, as I already said. Do you really need it? Is surgery from the primary tumor justified in metastatic breast cancer? Is radiotherapy in addition to surgery or just as the only treatment justified for the primary tumor is justified in metastatic breast cancer? So theoretically, what should be the benefit of getting local control in a patient who already has disseminated metastasis? You reduce the total tumor burden and may enhance the effectiveness of your chemotherapy. You stop additional reseeding of tumor cells from the primary side to the systemic, to the system. You limit the emergence of chemo-resistant cell lines as they continue to divide cells with, probably this is an assumption, with resistance develop. And of course you prevent uncontrolled chest wall. Like this situation, you don't want to see a patient. If she has metastatic disease, you would like to remove this tumor even for palliation. Can surgery accelerate relapse? There is a patient with metastatic disease, you do mastectomy. Do you worsen the prognosis by removal of inhibitors of angiogenesis perhaps, or by release of growth and immunosuppressive factors in response to surgical wounding? You do surgical wound or a growth factor, maybe you enhance the metastatic spread. So this is a theoretical question. However, I think we have, we don't have clinical, for sure, evidence to prove it that we accelerate the disease. However, we have one study published recently in the San Antonio meeting from India, I'll touch upon that study later, where they could show that patients who had local regional treatment for stage 4 breast cancer had more metastases. Their metastasis-free survival was worse, this is the green line, compared to patients who did not have treatment of the primary site in the presence of metastatic disease, which may make you think maybe this local treatment made the prognosis worse, or could potentially make the prognosis worse. So the conclusion, however, only this study is that the role of local therapy in women with stage 4 breast cancer should be re-evaluated with randomized clinical trials, and we'll show what is happening. Now, there are believers and non-believers. The non-believers state that there is no benefit to local regional therapy. Now, like a study by Dominici, a retrospective analysis, where they could show that if they did or did not do surgery on the primary site in the face of metastatic disease, didn't influence survival. The number of radiate patients in this study is small, so you cannot say a word about the role of radiotherapy. However, no benefit to doing local surgery in the face of metastatic disease. The believers in doing local treatment in the face of metastatic disease show retrospective series, and there is a number of series. I will, for the sake of time, I'll show you like series from the American National Cancer, American College of Surgeons, the SEER data from Harvard, Baylor, MD Anderson, all important places, Washington University, from the Netherlands, from Eindhoven, and from Geneva. These studies have shown that as if by doing local treatment in the face of metastatic disease, you reduce the risk of death, you improve the results. However, one should be very cautious about the interpretation because these are retrospective analyses. You don't know what was the selection for. Maybe they took the good patients to be treated locally with good feature, etc., etc. It's not the treatment, but the natural history, the nature of the disease and the condition of the patient that influence survival, and not the fact that you treated the primary site. How about post-operative radiotherapy? Again, for the short of a time, there are only a few series, retrospective. You can see that 3 of them showed that if you add radiation to the local disease, it's better compared to no radiation, and 2 studies did not show any benefit to doing radiation in addition to surgery. Selection criteria. There is a belief that if you treat with local therapy in patients with only bone metastases, then there will be a benefit. Again, there are studies pro and con. Benefit to radiotherapy, study by Rapiti and Barbiera, showing that if it's isolated bone metastasis, there is a benefit to treat the local site by the fact the patient is in stage 4. And Blanchard and Lescaudin, French, they showed that there is no benefit to adding radiotherapy in isolated bone metastasis, no benefit to treating the primary site. And there are 2 studies from France, from, I hope I will pronounce it properly, René Huguien's study and the Institut Gustave Roussy study, looking into the role of radiotherapy in patients with metastatic breast cancer. So the first René Huguenien Cancer Center from St. Cloud, France, you can see that 78% of their patients receive radiotherapy alone, 13% surgery plus radiation, and 9% surgery only. This is a retrospective. This is a study, but it's not a randomized study, so they could separate between patients who had systemic therapy only and systemic plus local treatment to the local site. And you can see that those who had local treatment at a median follow-up of 39 months, their 3-year survival was better compared to patients who did not receive local regional therapy. But there was no difference in the overall survival, only better local control. Again, the same caveats. You don't know what the selection to be treated, why some patients were treated by local therapy and the others are not, and you can presume that these are the better patient, and maybe they had better prognostic features which explain the better results. The Institut Gustave Roussy, again, 239 patients with stage 4 disease that were treated by local therapy despite the fact that they had metastatic disease, and 147 received radiotherapy only, surgery plus radiation in 92 patients, and one can see that adding radiation to surgery was better than radiation alone in terms of the disease-free survival, and there was a difference in the overall survival, but this was not statistically significant. And if you look at the long-term, if you look at the features, then these differences kind of don't exist. But however, one can say that there was local control in 85% of the patients who received only radiotherapy to their primary site, which is of course obvious. Now, how about randomized studies looking at this issue? Currently there are 6 studies looking at the role of local therapy in metastatic breast cancer. 2 of them were published in the San Antonio recent meeting in December 2013. And 4 of them are not yet published from Japan, USA, Canada, Netherlands, and Austria. We should await the result of these 4 randomized studies. But let's see what we have now published. in conferences. There are the Tata Memorial Hospital from India, published by Badwe, presented by Badwe, and Soran et al. Presented for the Turkish Federation of Societies for Breast Disease. They have a protocol looking at the role of local therapy in metastatic disease. And just quickly going over the slides, first the slides from India. Surgical removal of the primary tumor and axillary lymph node in women with metastatic breast cancer. And as you can see, all patients with metastatic disease receive first chemotherapy by anthracyclines plus taxanes. Then they were randomized either to receive local regional treatment or not to receive local regional treatment. And one can see that there was no difference in the overall survival whether they receive local treatment or not. Even if they look at certain features, it's the same, no difference. However, as I showed you before, there were more the metastatic free survival was better in those who did not receive local treatment, which gives you some suspicion maybe local treatment could be bad for these patients. And then the Turkish study by Attila Soran, here they randomized patients between getting first, these are all stage 4 patients, getting first systemic therapy versus getting first local regional therapy and then systemic therapy. It's similar but a little different. So in the Indian study, everybody received chemotherapy, then randomization between surgery, no surgery. Here, from the beginning, you go either for chemotherapy or for local treatment, even though you have metastatic disease, and their survival is the same, no difference. However, if you look at subset analysis that was presented at those with bone metastasis only, those who had the local regional treatment had better survival, but is of course preliminary in subset analysis. So the conclusions, there was no statistical differences in overall survival at early follow-up, and there were more local recurrences in those who did not receive local therapy, but there were potential subgroup differences. I will not count them, I just named them before. This is the ECOG study looking again at the role of surgery in metastatic breast cancer. We just skip quickly for the sake of time. And what are the take-home messages? Because we are being faced with this issue, I think, almost on a daily basis. Patient comes to you, she has HER2 positive breast cancer, ER/PR negative, with metastatic disease. You give the chemotherapy plus Herceptin, plus pertuzumab now, and miracles, everything disappears. But there's still a tumor there in the breast. Should you operate it, right? It's a common question. Well, the take-home message, my take-home message is, the survival advantage of local regional therapy in metastatic breast cancer has not yet been proven. Local regional therapy in metastatic breast cancer improves local control rate. However, it may accelerate metastatic dissemination if we believe the initial results from India. Local regional treatment in metastatic breast cancer may benefit certain subset of patients. So it should not be offered to metastatic breast cancer patients with asymptomatic primary tumor or regional metastasis outside the frame of the clinical study, or you should use your common sense case by case if you don't have a study. And the open questions that are still need to be answered, but I'm afraid, Philip, I think they will not be answered by any radiotherapy group, because I don't see that somebody will support a study looking at the role of radiation in metastatic breast cancer with local disease. Type of treatment should be surgery plus post-op radiation, exclusive radiotherapy. What should be the volumes, the dose, the fractionation, the timing of the treatment regarding the systemic treatment. All these are open questions, but unfortunately, to answer these kind of questions, you need a big study with a lot of funding, and I don't see that anybody will fund, so probably the answer will be in the future, wait for these other studies that I counted and use your common sense in the decision making. Thank you very much.
Thank you very much. We had in the Netherlands indeed a trial and we needed to close it due to poor accrual. The problem with the trial is a camel is a horse designed by a committee. We discussed 3 years about the trial, and from the initial very simple setup yes, no local regional treatment. It became into a very complex, ridiculous approach, and I think they included 5 patients in 2 years, which closed. Yeah, but if you do a trial in this kind of disease, keep it short and simple. Absolutely. No questions, so we will slide.